So before we finish up on HER2, I just want to kind of ask people their opinion about some evolving trials, some of which have been presented recently and some of which are still in progress. The first one actually is Bolero-3, which was presented at this year's ASCO meeting. It's a trial of second-line trastuzumab and vinorelbine with or without everolimus in HER2-positive metastatic breast cancer. In this trial, which was reported by Ruth O'Regan and her colleagues, there was a small improvement in progression-free survival, about a month, a little over a month, with the addition of everolimus. And I'm curious to hear people's comments about that before we all talk about kind of our favorite trial going forward. What do you think about the combination of everolimus and trastuzumab? Any comments?
I don't think any of us think it's the next best thing to sliced bread. I mean, I think that, had more toxicity and minimal improvement in efficacy, and we have so many other agents available that it's just not, this trial doesn't impact clinical practice.
The only thing I would say is that in the ER-negative population on the subset analysis, there was more benefit. In the ER-positive, it was like right on one. There really wasn't anything, suggesting you wonder whether the estrogen receptor was being a little bit more upregulated by blockade of both HER2 and mTOR. And that maybe ER needs to be blocked. That's an important question for a clinical trial to look at that blockade. But I would put it on the table as an option for patients later line, particularly for the ER-negative disease, whether or not we will see that patients with PIK3CA mutations may particularly benefit, as we don't know yet from the Bolero-3 biomarkers. But for ER-negative, HER2-positive, I do use it. And I keep it as an option for patients.
In combination with chemotherapy?
Yes.
With vinorelbine?
Yeah, like the Bolero-3.
I haven't given it that way. It's an interesting question about whether or not one should. I mean, I think that I'm also influenced in terms of what it's going to do for clinical practice, that, we have all these new drugs that are going into the adjuvant and neoadjuvant settings. And just to quote George Sledge's recent talk at the ASCO Breast Cancer Symposium, I mean, it's really hard to get better than 92%. That's what's being looked at for the next set of trials, which, the so-called, I think, Caitlin trial, that I don't know where we're going to put drugs like everolimus and afatinib and drugs that may have more toxicity.
Well, that brings us into kind of the last piece to talk about in this section. And I'll go through a few of the trials and ask comments. I mean, that gets us to kind of thinking about new agents. I-SPY. I think Hope is a good person to talk about I-SPY. Where do you think I-SPY is going to take us?
Well, this is actually, I think, the wave of the future, and it is actually a very novel trial design, and the statistical design is set up by Donald Berry, who really has put forth the idea of adaptive randomization in clinical trials as a way to come to a solution about what agent helps what group of patients biologically more nimbly with a smaller number of patients, and also allow trials to learn as we go along. So we all know we've done trials that had negative results, but the control arm did much better than we thought, because when the trial was designed, we didn't have a specific treatment, or patients did better. Or we have trials where the results have been questioned because the control arm did worse, because the people who are recurring have more therapy than they did when we started. This kind of trial avoids that, and it also avoids trials like Beatrice, which might test all patients with triple-negative breast cancer with bevacizumab and just see that everybody did really well with intensive chemotherapy, and bevacizumab didn't add to the larger trial population. So what this is it's a continuously changing number of arms. Patients who have at least a 2.5 centimeter tumor undergo a core biopsy and an MRI scan. The core biopsy is tested with the 70-gene mammoprint array by Agendia, and you either have to be high risk by mammoprint or HER2 positive or ER negative. And that makes up 10 different signatures that are then randomized with a separate consent form to receive either a novel agent with standard neoadjuvant chemotherapy, weekly paclitaxel and doxorubicin and cyclophosphamide, or a control arm. And then what you do is you compare each experimental arm to the control arm to concurrently randomize controls, so that will change. For example, an arm that opens next year would be compared to the controls that are randomized then. So you actually could change what the control is over time as well. And rather than randomizing 1-to-1 or 2-to-1 or whatever you do, you actually get MRI results as you go along. You feed that information back into the randomization engine using a predefined algorithm, and you change the number of patients based on the signature that seems to be benefiting or less benefiting to each arm as you go along. And then that data is confirmed with the pathologic complete response data that you get at the time of surgery. And we're presenting one arm of the I-SPY 2 trial, veliparib, the PARP inhibitor, and carboplatin with paclitaxel compared to the control arm in patients who have HER2-negative disease. And then there was a press release last week from Puma about neratinib graduating from the I-SPY 2 trial as well with positive results. So it'll be interesting to see how the information is received. And what the whole idea behind this design is that it can power. You have at least an 85% predicted chance that a 300-patient randomized phase 3 trial will be positive in the neoadjuvant setting with PCR in the signature that the drug graduated from in I-SPY 2. So it's a cool idea.